All right, good morning, everyone. We are going to get started. My name is Dana Slowinski, and I am co-owner of the Family Recovery Centers. And we would like to, on behalf of ERC Insight and Family Recovery Centers, welcome you to this very informative webinar. I wanted to take just a minute to talk a little bit about Family Recovery Centers. We have an evening adolescent intensive outpatient program. We are located in Lake Bluff, Hoffman Estates, and St. Charles. We're a DBT-based program, so that means that we've been intensively trained with Marsha Linehan's group, and we also work on a regular basis with a consultant from Marsha's team in order to ensure that we stay cutting edge and on the forefront of DBT treatment. Because we're DBT, we work with kind of a wide range of adolescents, ranging from depression, anxiety, maladaptive behaviors such as self-injury, substance use, suicidal ideation. And we have, we incorporate a lot of experiential work into our program as well. So we have an art and yoga therapist, and we incorporate a lot of meditation and mindfulness type programming as well. Two things that I would like to highlight is that we have a very strong intensive parent component. So parents are actually on site with their child 2 of the 4 evenings. And so they are learning the skills didactically right along with their child. And then they're also doing their own work in processing and really focusing on their dynamics and their role within the family. So we're really looking at the whole family system. And then we also have a 24/7 on-call. So we are available, our staff is available 24/7 to patients and parents to help with skills coaching and to help them when they're having urges or they're in a crisis moment, to help them identify skills and also work through those moments in their actual real life outside of just the programming when they're with us. And that is really us in a nutshell. Ryan and I really believe that it truly takes a village to help and to provide treatment to patients and their families. And we believe in, in working with our community relationships to provide effective, comprehensive, compassionate care. And we are very grateful for our relationship with ERC Insight. And with that, I will turn it over to Terry Sendejas, who is the Professional Relations Liaison with ERC Insight.
Thank you, Dana, and good morning, everyone. I just want to start thanking Dana and Ryan and Family Recovery Centers for this invitation. As Dana mentioned, we're always about collaboration and finding a good fit for a client in need. A little bit about ERC Insight. So ERC Insight basically stands for Eating Recovery Center and Insight Behavioral Health. We specialize in treating eating disorders and mood anxiety and trauma-related disorders from children 10 and up, so children, adolescents, and adults. We have 108 residential beds, locations in Northbrook, which is our child and adolescent program. We have 36 beds there. So we have 18 for eating disorders and 18 for mood and anxiety kiddos, and they are on separate units. Our other 3 facilities are located in the Loop. Those are primarily adult focused. We do have our eating disorder program, which is adolescents and adults. We have our adult mood and anxiety program, and we also have our adult binge eating program, and they're all located in the same vicinity within the Loop area. We currently are offering in-person PHP, and that includes a location we have in Oak Brook, as well as we continue to provide our virtual intensive outpatient. One of, I think, our focuses in terms of our treatment modalities are really also, as Dana mentioned, we're very DBT focused with our kiddos, our children and adolescents. A very strong family component, utilizing EFFT, which is emotional. I just drew a blank. So apologize. It's the emotional focused family therapy. There are kiddos there as well. And we're big also on exposure response therapy. If you have any questions, feel free to reach out. In the meantime, what I'd like to do would you like me to go ahead and introduce Leah? Leah Young is an LCPC, and she is the clinical manager of the Addiction Recovery Track at Eating Recovery Center in Insight Behavioral Health. She has been with ERC Insight for over 4 years, and she came in to introduce substance use treatment and education into the mood and anxiety and all our programming, really as a co-occurring focus. We do not do primary substance abuse treatment, but we do the secondary, and she'll obviously talk a little bit more about that. Leah earned her master's from Chicago School of Professional Psychology in 2007. Upon graduation, she was hired at Resurrection Behavioral Health, which is now Amita Behavioral Health, and she had run the evening intensive outpatient groups who struggled with substance abuse disorders. She was promoted to program manager, and she ran that for several years before coming to ERC Insight. She lives in Chicago with her exuberant 7-year-old daughter, her hilarious husband, and her 2 annoying cats. I'm able to say that because she wrote it. And she also enjoys some good punk rock music, except for the exceptions of the cats. So I'd like to please welcome Leah Young.
Thank you, Terry, very much for that. And Dana as well. It's so exciting to hear about the work that you're doing. It's so needed. And so I actually I'm getting a little bit goosebumpy here, thinking about all the folks there who are doing their best to bring services to families who need them. So today we were talking about how to recognize eating disorder behaviors in the substance abuse population, but also vice versa, and recognizing those substance abuse behaviors in the eating disorder population as well. And I'll talk a bit about adolescents. I'll weave that in terms of some statistics. Please feel free, if you have any questions, I'm happy to answer them during. You can send them in the Q&A, I think, or the chat box if the Q&A doesn't work, but I think the Q&A, and then Terry will interrupt as needed, and I will either address them on the spot or let you know that the answer's coming up for those of you who prognosticate. Talking today about this, we're definitely going to take a look at some of the similarities and differences between the two. We want to talk definitely about integrated treatment, which is starting to really become something that's obviously on the forefront here of what we need to do to really treat people with best practices. I do have a quick, well, let's see if this works. Okay. Oh, so I'm not able to forward my slides for some reason. So we might have to just hold off for a moment while I figure this out. Bear with me. Yeah, that's not working. Okay, so what I have is a conflict of interest statement, so I'm probably not going to be able to read that to you. I'm going to have to stop share, forgive me. I've not had this happen before. So I think part of the problem is that, let's see if this works. No. Oh, there we go. Yay. All right. I don't know what I did. But we have here a conflict of interest statement. I don't have any conflicts of interest. I have no affiliations with or involvement in any organization or entity with any financial interest, et cetera. No stock ownership, no other equity interest, no non-financial interest in the subject matter or materials discussed in this manuscript. I work for ERC Insight, and that's it. If you have any questions, let us know, of course. So I want to start off with some co-occurring statistics. What the statistics say is that about 50% of individuals with an eating disorder are abusing prescription or over-the-counter medications, illicit drugs, alcohol, and that's about 5 times the abuse rate seen in the general population. What my experience has shown me is that that number is more like 75%. At any given time, at least 3/4 of the unit is probably working with me on some level or another. Oftentimes as a preventative kind of measure. It doesn't mean that they have crossed the line, that invisible line into addiction quite yet, but certainly it's something that we want to pay attention to earlier on, and I'll talk about that a little bit later. People, kind of on the flip side of that coin, somebody who already has a substance use disorder is 10 times more likely to have an eating disorder. And we'll talk about some of that trade-off and what that can kind of look like certainly we are seeing, in layman's terms, behavioral swapping going on quite a bit, but we'll discuss that further. A bit of the lifetime rates of any substance use disorder in the various eating disorder subgroups, which I will talk a little bit about for those of you who don't have a lot of familiarity. Anorexia nervosa, about 27%. They really all hover around the same percentage, quite honestly. Bulimia nervosa and binge eating disorder, very close in terms of percentage within the various eating disorder subgroups. So it's there, and we need to be aware of it, or else we are not doing our patients and clients a good service. What I meant to say is we're doing them a disservice. Isn't that so much more neat and tidy? So what we see is that both have high standardized mortality ratios, so especially because of medical complications and suicide. And so that's very difficult to treat. One of the things that we often find, especially with patients who struggle with anorexia, like classic anorexia nervosa, is they need treatment for both. And if they go to a substance use facility, they can't be taken because they need to get their eating situated, and they go to an eating disorder facility and they can't be taken because they're drinking or using. And so they're left with nothing and feeling like there's nowhere to turn. And so that really increases feelings of hopelessness for a lot of those patients. And they're one of the higher risks for suicide amongst the eating disorders. By the way, for those of you who don't know what an SMR is, and quite honestly, I didn't remember what it was. I knew that I'd learned about it at some point until I had redone this presentation a while back. But it's expressed as a ratio or a percentage typically, and just what it basically says is that within a study cohort, we take a look at the increase or decrease in mortality, kind of in comparison or in respect to the general population. So how many deaths we would observe in a group of general population folks versus amongst our eating disorder and substance use disorders. As eating disorder symptoms become more severe, the number of different substances used increases, and we can probably all imagine why that might be. We're looking for relief, we're looking for ways to cope, we're looking for maybe ways to manage or even engage in our eating disorder, and so we start to kind of throw everything at the wall to see what sticks. About 30 million people of all ages and genders suffer from an eating disorder within the United States. And when we get to the next slide, you'll see that we don't have enough treatment options for those folks. We do see OSFED, and I'll talk about that momentarily, is significantly more common in people with a substance use disorder as opposed to those who don't. So we see those two go hand in hand more often than somebody without a substance use disorder having OSFED. I mentioned that, eating disorders, particularly anorexia, have the highest mortality rate out of any mental health issues. And then, of course, we see anorexia and substance use with a higher suicide rate than the other diagnoses. So these are important things to consider. Another important thing to consider is the eating disorder treatment disparity. So this is from 2014. I did try to find something a little more recent. I have not gotten my hands on it yet, though I feel certain that there is something more recent. And I can tell you that that little tiny green bar has changed since 2014 due to other facilities, but I gotta say, largely in part due to all the beds that we've added in the last couple of years. But what we see here is there are about 3,000 acute care hospital beds for every 1 million US residents, okay? For every 1 million people diagnosed with a psychiatric disorder, there are about 1,400 beds. That's a pretty big disparity alone. But when we look at eating disorders, we see only 224 eating disorder beds available for every 1 million people diagnosed with an eating disorder. That's abysmal. And since 2014, as Terry mentioned, we have beds in Dallas now. We've got more beds in Denver. We have, more beds here with adolescent, et cetera. So we have added to that. I'm certain there are other facilities that have as well. So that number has bumped up a bit, though, as you can probably agree with me, not enough. So I want to talk a little bit just briefly about the eating disorder diagnoses. This is just a basic 101. So anorexia nervosa, which most of us are familiar with, it's characterized by starvation, right? Self-starvation and excessive weight loss typically. And there are two diagnostic kind of subcategories, if you will. There's restrictive and there's binge purge anorexia. So the binge purge anorexia can oftentimes, to the untrained eye, look like bulimia when it's not, or like a binge eating disorder when it's not. And that's where having a professional come in and diagnose is important. Bulimia nervosa is what we all have come to know as the cycle of binging and then compensatory behaviors. We often think of self-induced vomiting, but that can also include laxative abuse or exercise, whatever it might be, to compensate for the effects of the binge eating episode that they've just experienced. Whereas binge eating disorder is characterized by recurrent binge eating without regular use of compensatory measures. Now, there may be occasional use of compensatory measures, but it's not frequent and it's not regular. I talked about OSFED. That's a lot easier than saying other specified feeding or eating disorder. And that's just kind of abnormal eating without all of the symptoms required that, to tick off the boxes to get a full-blown diagnosis of anorexia, bulimia, or binge eating disorder. An example is night eating syndrome. It's not exactly binge eating, but it's something that it can interrupt people's functioning on a lot of levels. And then we've got ARFID, which is avoidant and restrictive food intake disorder. And we typically see that in childhood or infancy, but it can also be found in adults. And this is, a lot of issues with texture, happens for folks, and again, they might carry that into adulthood. We also see that sometimes trauma contributes to this, or if I've choked on something before, I may develop a fear of that particular food or subgroup of food. So just to give you some ideas of the eating disorder diagnoses that we currently work with, and if you see any of AN, BN, et cetera, you'll know what those mean. So just a brief glimpse into childhood, and since a lot of folks here today probably do work with children, so you may know this, but we see some of the most common psychiatric disorders in childhood being anxiety, ADHD, and other disruptive behaviors, and then depression and some amount of bipolar disorders. Eating disorders is about 2.7%. That to me is too much. And we'll talk a little bit on the next slide about what that looks like. And this is in particular with teens, ages 13 to 18 in this particular, I just said that word twice, sorry. And it's from childmind.org. And there may even be something, I think this is actually fairly up to date, quite honestly. I think I got it late last year. So really understanding the eating disorder, that 2.7%, dieting and disordered eating is really common with teens, which makes sense. And if you take a look at, identified females versus males, those trying to lose weight, who are actively dieting or who are exercising to lose weight, don't even get me started on how, the schools have made an attempt, and it was a good-natured one and well-intended, to try to teach, healthy movement and healthy eating. Unfortunately, a lot of what that approach has done is stigmatized people of larger bodies and made them feel like they were doing something wrong. And so there's a lot of research to be found. One woman in particular, whose name I can't remember off the top of my head, has compiled a ton of research about programs that teach eating for nutrition and movement for just general health, et cetera, without talking about looking different and those kinds of things that are way more inclusive of people of different body types. So that's the direction we'd like to see things go in schools. But one of the best known environmental contributor, I hate to be this person, it's social media and media in general. So it's this sociocultural idealization of thinness. And by the age of 6, girls especially start to express concerns about how their what the shape of their body looks like, or their weight. And I've seen, Terry mentioned I have a 7-year-old, and she's got a little bit of a round belly. We have never, ever mentioned anything about it otherwise. It's who she is. That's her shape at this point in time. And she noticed it the other day. She noticed that a few of her friends have flat bellies and they're wearing bikinis and things like that. And yes, for those of you who don't have kids and are feeling a little shocked, yes, they are. But she's noticing that now. So the parent trying to figure out how to handle that without creating, some sort of neurotic response to it, to use old-fashioned language, because that's how I'm feeling. But in any case, we are noticing this very early on, and 40 to 60% are concerned about their weight or about becoming too fat. Of American elementary school girls who read magazines, we see that 69% say that the pictures influence their concept of the ideal body shape. Now, there's a good movement in media now where they're including people of all sizes and all different types of bodies with different types of skin. I've even seen, people with stretch marks, things like that. So I'm hoping that can contribute and change some of that for younger generations, but I don't know that it's going to happen right now. And then a lot of folks, almost half of those kids, they want to lose weight when they see those pictures. So really monitoring what our kids are taking in, having discussions with them about it, opening the door. Many of you who work with kids know how to have those kinds of discussions, and I think it's important to make it okay to talk about. In homes, I think most parents are just doing their best. Because although there are a million handbooks, there is no handbook really for raising kids. And, I think that being cautious about, we talk about eating healthy, or we talk about foods as good or bad, if mom or dad is on some sort of gluten-free diet, that isn't necessarily due to celiac, or they cut out, all white starches, the kids take that on, and sometimes they kind of explode that into an eating disorder. So we want to be really cautious about that. So I want to talk a little bit about behaviors that may be indicative of eating disorders. Please notice the word may is underlined. Any one of these alone, or these together in like one instance, doesn't necessarily mean that someone is engaging in an eating disorder or disordered eating, which is slightly different. That's where we start to see some of the behaviors. But if we're starting to see a pattern or several of these happening over and over again, we definitely want to pay attention to that. So consistently leaving the table within 10 minutes after eating a meal, especially to go to the bathroom, but not always. Let me just do this instead of standing here holding it and then risking spilling it. Because one of the things, people who have eating disorders are very good at is they're very smart and have really, the eating disorder is sneaky, and it has really good ways of covering up and hiding. And so we have had patients who find ways to purge, not in a bathroom, so it's not as obvious, and hide and then get rid of the evidence later, et cetera. If someone is stirring or playing with their food rather than eating, eating disorders are very good at, and I'm referring to them as though they are a different entity from the person. And many of the folks that we work with kind of view their eating disorder as this separate entity. A lot of them name their eating disorder, in fact. So the folks with eating disorders, they get really practiced at making it look like they've eaten things on their plate when they have not. If someone is skipping meals consistently, what I will tell you is that people in certain positions, I'll just give an example, nurses, for example, have a really good excuse for skipping meals consistently, and hardly anybody ever questions it. And so those are some of the things I explore with, kids in school. It's a real good excuse to not eat because they're so busy with the finals that are happening or whatever it might be. So really paying attention to that and making sure that we're not co-signing skipping meals just because somebody leads a busy lifestyle. Skipping a meal and then overeating at another. Now, believe me, I've done that before. And if we're looking again at a pattern, we're looking at consistency. If they're consistently tired or fatigued, if they're setting goals and communicating goals around getting physically healthy, if they're exercising despite physical injuries. I've had lots of people continue to run even with stress fractures, even when their doctor says your heart is going to give out, you have to not exercise, they'll continue to do so. If they're exercising more than 1.5 hours a day, more than 4 to 5 days a week, or they're restricting entire food groups, talking about foods as good or bad. Now, let's be honest about that. We've kind of been raised to do that, to talk about foods as good or bad. And to get even more honest, yeah, there are some foods that aren't so great for us. But when we get into this black and white, kind of putting one food into one category and another in another, it allows us to very easily restrict and not ever maybe allow ourselves to have something that's bad for us. And restricting like that for many people is deprivation and ends up leading to all sorts of further issues, including binges, etc. Expressing concerns about becoming fat or being fat, gaining weight or losing weight while in treatment when that's not the medical team's intention. Sometimes that's the intention, but when it's not, we want to take a look at that. A lot of conversation about food, weight, the body, calorie intake, fat, carbs. When there's a lot of talk about that, there may be something going on, at least in terms of disordered eating. And then rigid eating patterns. Oh, but don't worry, I have 2 more slides of this. Cutting food, there might be some repetition here, I'm hoping not. Cutting food into small pieces, pushing it around on the plate I mentioned, taking tiny bites, chewing and spitting. Oftentimes they'll be very good at hiding it with a napkin or whatever it might be. Hiding food. We see a lot of folks hiding food as well, either to make it look like they have eaten or in order to save it for later. Feeling full after a few bites. If we see limited or increased liquid intake, we want to take a look at that. So we see some folks with eating disorders have a tendency to not drink any liquids at all, and we see others waterload, and they drink as many liquids as they possibly can, and that mix helps them to feel full. We already mentioned skipping meals, exercises for long periods, especially with an obsessional attitude. I guess that's important, even though that's a little bit repetitious. If we can't miss a day, if there's almost like a punishing kind of feeling around missing a day, even if it's due to something legitimate like illness or whatever it might be. Dieting or chaotic food intake. If somebody has a difficult time sitting still, they're constantly offering to run and do this or run and do that or doing chores, if they're bouncing their legs in their seat, a lot of times our eating disorder patients who are not allowed to exercise, at least not initially in early recovery, will bounce their legs in their seat or find other ways of getting movement in where it looks just like a nervous habit, but it's really them trying to burn calories. Making lists of foods and calories and charting all of that stuff. If you find them wearing baggy clothes to hide one way or another, frequent bathroom trips, diet pills or laxatives if you come across those, etc. Consuming large portions, often in private. And then what we have here are some behaviors that may be indicative that are more like how they might present. So socially withdrawing, increased anxiety. We may see a change in friends, much like we do with substance use disorders. Mood swings. If they start to get a little foggy or they have a hard time concentrating, when our brain is not getting enough nutrition, these are kinds of things that we start to see. We may or may not see weight fluctuations. I think one of the things we need to be very careful about, and I'll get into this in a little more detail later, is about making assumptions about what type of or whether or not someone has an eating disorder based on what they look like. We might see calluses or sores on the backs of their hands that would come from self-induced vomiting. Dizziness, freezing, if they're always freezing cold, sleep issues, etc. Dental problems we see a lot of, again, usually due to malnutrition as well as self-induced vomiting. If they're hoarding food, change in exercise patterns. Gum chewing, excessive gum chewing. That's another way to kind of stave off hunger cues. And then excessive use of caffeine or sparkling water. Again, those are ways of either decreasing our hunger cues or making us feel full. Okay. So those are some things to look out for and just have an awareness of and start to kind of tick off and then maybe have some conversations around. We'll talk about how to maybe start that kind of conversation. But what studies suggest is that it's important for clinicians to consider and screen for sub-threshold levels of eating disorders, in addition to formal eating disorder diagnoses. And this is true, by the way, for substance as well. This is prevention. So the earlier that we start to notice disordered thinking around food or body or exercise, the earlier we can address it and the more likely that we are to stop that progress of a full-blown eating disorder. So really paying attention to this early on is very important. So one of the things that we like to talk about is how eating disorders can hide behind substance use disorders, and honestly vice versa. But really, people who struggle with substance abuse, for example, may exhibit some eating disorder behaviors but they can be completely undetected. And I'll give a few examples. Normally, this is where I poll the audience and see if anybody can think of any, but that's not so easy these days. So I've worked with a lot of folks. As Terry mentioned, I came from primary substance use. And so a lot of times someone will stop drinking, and what do they often start to partake in? Sugar. Lots of sugar, ice cream, candy in their pockets, donuts at meetings, whatever it might be. And that is a pretty normative kind of response to not drinking initially. If that continues though, or it's happening with such frequency and in such quantities, it can start to lead to eating disorder behaviors. The other thing that we sometimes see is I've worked with a lot of folks who, again, who stop drinking or using, and they start running. They start running marathons. They start running 13 marathons a year. That is not healthy for the body. And so it's almost as though the addiction has swapped to something new. It doesn't mean that they are not sober and working a program, and we wanted to pay attention to those kinds of things because we've found another way that's really not healthy for our body. It's not balance. So the problem is that a lot of times we're like, wow, you ran 13 marathons. That's amazing. I could never do that. Boy, I wish I had the willpower. And what we do is we contribute to and co-sign these behaviors that may actually not be real healthy. Now, I'm not saying to go around saying, wow, that sounds really effed up to people, because that's maybe not the way to approach it. But I'm really proud of myself for kind of censoring myself. I apologize for the reference to a cuss word. In any case, we need to pay attention to some of these things and just really recognize that there may be something going on there where the addiction has switched to more of a compulsive behavior or to a different substance or food. Initially, the substance use might mask eating disorder behaviors or be utilized as part of the eating disorder pattern. So an example I often give is I work with a lot of patients who struggle with eating disorders who use stimulants in order to manage and as a part or a function of their eating disorder. I've seen it with alcohol. I've worked with 2 patients in particular who got to the point where the only time they could eat is if they were drunk, which of course led them to being drunk an awful lot of the time. And so part of the work that we had to do with them is, how do I learn to eat without being intoxicated? Both patients committed to sobriety, which is cool, and started to get their natural hunger cues back, and we worked on that, but it was not easy. So really paying attention to how these things can kind of mask. What I often do, where I work, because we're not primary substance use, we get a lot of folks, they're coming in for their eating disorder treatment or for their mood and anxiety treatment. They are not here to talk about substances. They do not like meeting with me typically. Because this is not what they're here to talk about, and why are you even asking me questions about how much I drink? One of the things that I often do is, even if a patient is not overindulging or abusing in any way, I ask them, let's say they only have a glass of wine or 2 on Friday nights with their girlfriends when they go out. And I'll say, do you notice that it interacts with your eating disorder at all? And sometimes the answer is no, but often the answer is, well, because I'm going to go out and have some wine, I don't eat lunch. Or they may find that they'll order some food with their girlfriends, but they'll really kind of push the food around on their plate instead because they're drinking and they want to make up for those calories. So while 2 glasses of wine in nobody's books, by anybody's criteria, is problematic, it's problematic, especially if their eating disorder recovery is important to them. And so these are the kinds of things where I sometimes get folks who are like, you know what, maybe I can't drink right now, which is like the coolest thing. And that doesn't mean that they'll never drink, but in early eating disorder recovery, for example, they may choose not to, just to really get that established. So we really want to pay attention to some of those things and ask the questions that aren't the real obvious ones. Again, we also talk about, I already mentioned several times about the behavior swapping, the turning towards other numbing mechanisms, or other coping, maladaptive, I guess we call them, coping skills, in order to help them with the unwanted thoughts, feelings, memories, the physical feeling in their body as their bodies change, that many of them are uncomfortable with. So an easy way of getting a general idea of whether or not somebody may be struggling with disordered thinking around food or their body is the SCOFF questionnaire. It is not the be all end all, much like the cage, for those of you who are familiar with that, but it gives us a little bit of an idea. And so you'll notice that this is definitely a British, because they say 1 stone for 14 pound, but do you make yourself sick because you feel uncomfortably full? Do you worry that you've lost control over how much you eat? Have you recently lost, or I would say, or gained more than 1 stone in a 3-month period? Do you believe yourself to be fat when others say you're thin? And would you say that food dominates your life? And so this is a good way to get a general idea of, okay, there might be something going on here for somebody. And then we can refer them to somebody who is an expert in eating disorders to learn more. All right, my little clock went off, so I just want to see, I know it's timing me up there. I just want to see how we're doing the time. Pretty good. All right. Okay, so just kind of continuing with the eating disorder piece of it here, what to ask and what not to say. And we'll talk about some of the things to ask. And so these are good open-ended questions to start the conversation. You know, what do you think about your body? How do you feel about it? What kinds of diets have you tried? Can you name some ways that you've tried to lose weight in the past? And just really kind of prompt them to give some answers to these. Notice that we're avoiding yes or no answers or questions. How have worries about eating your body affected your daily life? So this may be where we find out that, well, I don't want to gain weight because, you know, people in my family, they tend to gain weight. So, you know, I make sure that I exercise every day after work for, you know, I go in for, 2 or 3 hours, right? So that's the kind of thing that we want to look out for. How often do you make up for or spend calories after eating in order to keep from gaining weight? A lot of people are really misinformed about how calories work. And they think that if they eat a 200-calorie piece of food and then they go and burn 200 calories, there's some sort of equivalence there. I can't explain all of it because it's scientific stuff that is not my area of expertise, but they're not equivalent. Unfortunately, it's the message that media really gives, is that you can spend it, and then it's like you haven't eaten it at all, which is not the case. How often do you feel out of control when you're eating? How often do you eat for reasons other than being physically hungry? So we're looking for some of that emotional eating, boredom, loneliness, etc. And getting them, they might say, I don't know, 3 or 4 times a week, but we want to can they talk a little bit more about it? So try to elicit as much information as possible. Some things to not say: you don't look like you have an eating disorder. So this refers back to, assuming that because somebody looks a certain way, they don't have an eating disorder. We have a lot of patients in our eating disorders program where the focus is more on anorexia nervosa and some of the bulimia, who live in larger bodies. And so people assumed that they couldn't possibly have anorexia. And then we have people in our binge eating program who live in either what would be considered, I suppose, an average size body or even thinner, and they don't look like they have a binge eating disorder, but they do. And so we have to be really cautious about that. And I know of patients who have had experiences with doctors who have said this kind of thing to them, which only allows them to keep having an eating disorder for a bit longer. Here's another good one. Wow, I could stand to lose some weight myself. Those are the kinds of things we want to be careful about. I imagine that most of us, on the webinar today would not do those kinds of things, but your average Joe might. And some of the conversations that we have with our patients is how to manage when people do say these things to them, because they're going to be said. So we want to help them be able to manage those experiences without spiraling into eating disorder thinking and behaviors. You look good. You look healthy. What our eating disorder patients hear and what they translate, their little babblefish in their ear, for those of you who are Douglas Adams fans, translates that into fat. And so it's normal, especially when you haven't seen somebody because they've been in treatment for a while, to want to tell them that they look healthy, because maybe they actually look healthy when the last time you saw them, they did not. And so we do a lot of coaching with families and friends and whomever we can get involved in learning how to just say something like, "It's really good to see you," or "I missed you," instead of commenting at all on how they look. Not even that you like the color of their shirt. It's just better to stay away from anything that reminds them that you've drawn attention to your attention has been drawn to some part of their body. And that doesn't mean forever. Again, we have to teach them that people are going to say these things. These are normative kind of things to say in our society, and how do we manage that? And those who are closest with them can learn how to be, to just choose different things to comment on. It's not about walking on eggshells. It's just about maybe focusing more on, it's good to see you, as opposed to you look healthy, or, you know, those kinds of things. Just eat healthier foods. That one is one of my favorites. Like, oh, I hadn't thought of that. And we'll talk a little bit more about how this is seen in terms of morality. You don't look fat, or you're too skinny, or whatever it might be. Really commenting on what a person looks like. So really focusing more on the person as opposed to the package is very important. Okay. You know what I have a little bit of note here, a little bit of notes that I should probably bring up. So the patient's awareness of their eating disorder might make them minimize or be less truthful when asked these questions, right? So pay attention to statements that seem out of touch with reality. For example, a 5'6" tall woman who's 90 pounds, who's referring to herself as fat. So, you know, noticing that, noticing anything that sounds like kind of isolation, not attending parties, avoiding people, that they don't have to worry about the food or eating uncomfortably around others or whatever it might be. So just really paying attention to those things is important too. Okay. So shifting just slightly over into substance use disorders, the age of onset of types disorders in children, of course, we see some of the typical that we talked about on the other slide: anxiety disorders, ADHD and behavior disorders, mood disorders, and then substance use. The median age of onset is 15, median. So there are kids, as many of us know, who are starting way younger, and they are definitely exposed to it way younger, even if they're not using. They may know somebody who is or who has tried. I know that I've had a lot of folks that I've come across become surprised that I would be so candid with some of like our 12 and 13-year-olds. And, you know, I feel them out first. I don't just go in guns a-blazing talking about heroin or anything along those lines. But certainly a lot of them are being exposed to either hearing about it or their friends who don't have an understanding of it, thank goodness, but talking about it, making it. I worked with one 12-year-old at ERC several years ago who said that her friends in her grade, like the boys, one of the games they liked to play was to pretend like they were heroin addicts. So, you know, they're hearing about this kind of stuff at the very least, and it's not too young. It's never too young to start talking about it. It's how we talk about it with the age. You know, we want to know our kid or the child that we're working with. We want to know their developmental kind of capacity and their emotional capacity and those kinds of things, but we can always start to talk about these things. So, substance abuse and mental health disorders. This isn't my favorite slide just because of the way I wrote it. It's just a bunch of words. Sorry about that. But kids with anxiety disorders may use substances to calm themselves down before social events or going to school. And a lot of the patients that I've worked with here started drinking in high school, some of them in middle school, and a lot of times it was before school so that they could just kind of manage the anxiety or, you know, if there was bullying or whatever it might be, it helped them to really disconnect from a lot of that in order to be able to be in school. We also may find that kids who are depressed can use substances to cheer themselves up or blunt the irritability that is associated with teen depression, depression in general, really. And especially if it's something that their group of friends is doing, right? It makes us part of, and we can contribute to those feelings of like celebratory or happiness, again, disconnecting us from our ruminating thoughts or the critical self-talk or whatever we have internalized there. Those kids who do struggle with mental health issues and learning disorders also struggle with self-esteem, and they have that sense that there's something wrong or flawed, or at the very least that they're different, and they really want to fit in. You know, kids in particular, as we know, really want to fit in somewhere with somebody, and so a lot of times using substances with friends is the one way to do it, and it allows them to not feel so different. And oftentimes a word that I hear associated with use is, it helps me to feel normal, whatever normal means. All of these kids are at risk for developing addiction because their brains are still learning. And so they can learn, kids, because of their developing their brain, can learn addiction way more quickly than somebody who starts drinking or using as an adult or after their brain has developed. And there are always outliers, right? But drug use, substance use, eating disorder behavior, other compulsive behaviors like spending, etc., they are learning. There's a reward pathway that's involved. And so they learn a whole lot more quickly. It becomes really ingrained in their brain, and it's very, very challenging to make changes. Also, substances alleviate all of the above, right? They make us feel better, or else we wouldn't use. They make us feel less anxious. They make us feel less depressed, etc., or else we wouldn't use in the first place. But oftentimes we find that the teens end up feeling worse when they're not using. And so they want to continue to use as often as they can. And then, of course, substances affect the same areas of the brain that some mental health disorders operate in. And so we can see increased incidence of things like depression, bipolar, etc. Okay, going to talk a little bit about the substance use statistics slide here. And so what we have is so some of these are a little bit old. I'm looking at that 2010 one. But I know I put this slide together last year, so that must for some reason have been the most recent. I'll have to take a look again, see if I can update it. But in any case, amongst youth ages 12 to 20, according to 2009 National Survey, about 27% reported drinking alcohol in the past month. And of those, 18% reported binge drinking. Now, we have to understand what binge drinking is. Most people, especially teens, do not. There's often this idea that if I'm drinking 12 or 14 or whatever, that's a binge. And it is. But so is drinking 4 or 5 drinks in a relatively short period of time, a couple of hours, for example. So binge drinking, I think, for many people is surprisingly a lot less intake than one would think. So amongst 8th, 10th, and 12th graders in 2011, we're looking at nearly the same percentage. About 27% had tried cigarettes in their lifetime, and about 11 or about 12% reported that they'd smoked within the past month. So, I'm not talking about vaping today because I've heard that you've gotten some recent information about that, so we won't do that. I'm seeing, okay, Terry, you'll interrupt if there's a question, I assume. And then studies report that the degree to which teens disapprove of marijuana use and the perceived risk associated with use has recently begun to decline. And so we really want to keep an eye on that. I think there's a lot of misinformation in the media about marijuana. They're not doing a really good job of differentiating, for example, between the metabolites in marijuana, THC and CBD, and the others, about 60 of them. Though they're, okay, that's another presentation. It's not 60 different metabolites that do 60 different things, but in any case, they're not differentiating between those two major ones that we often talk about. And they're also, there's also kind of this idea or this presentation that medical marijuana is a prescription when it is not. And we don't have any of the scientific backing behind it as a medicinal. We're working on it. The world is working on it. People are doing research, which is good. But I think that some of that is contributing to this idea that, well, it's really not that big a deal. And we're seeing a huge increase in kids using really concentrated forms of THC like dabs, wax, shatter, in cartridges and things like that. And then what we're seeing from that, resulting from that, is an increase in admissions to hospital emergency departments with psychotic breaks. So I think a lot of that has to do with that perceived risk is declining. And painkillers are one of the most commonly used drugs by teens after tobacco, alcohol, and marijuana. I mean, honestly, just pills in general. I'm sure many of you have heard of the pill parties that they'll have. And they all go to a friend's house. They just put all the pills in a bowl that they could swipe from their parents' cabinets or whatever it might be. And you just take a handful. Often no idea what's in there or what mixing them might do, etc. But you got painkillers. I also think that they're really accessible. Painkillers are really accessible. All right. So your kind of twin here to the SCOFF questionnaire is our CAGE questionnaire. So for those folks who want to screen for potential misuse or abuse of substances, we can take a look at this, which is, have you ever wanted to cut down or felt you should or tried to cut down on your drinking? That's our C. The A is, do people annoy you by criticizing your drinking or making comments about it or whatever it might be? It doesn't have to be direct criticism. I know I've worked with a lot of people whose teenage son might say something like, oh, you're having another one? So it might not be criticism forthright, but it certainly is acknowledgement and calling attention to our drinking. Also substance use. It doesn't just have to be this CAGE questionnaire, yes, was for alcohol, but honestly, if somebody says yes and their substance of choice is something other than alcohol, then we're looking at that as well. Have you ever felt bad or guilty about your drinking or drug use? And then have you ever had a drink or used first thing in the morning to steady your nerves? And that's our eye opener. So really, that's, again, that might tell us that, okay, we might want to send somebody to somebody who's a specialist in substance use disorders to really get this explored a little bit further and see if there's something going on there. All right, so let's talk about some of the similarities. I had to go and make these slides fancy, so I'm gonna have to. All right, so eating disorders and substance use disorders typically begin in adolescence or in early adulthood. A lot of times when working with patients, they may not have known it at the time, but when they look back at their childhood, they say, oh yeah, I can totally see that I was doing this and this and this, whatever it might be. And they do both include behaviors that function to maintain the disorder despite harmful consequences. There's a high tendency for relapse with both disorders. It doesn't mean someone is doomed to relapse. I like to make sure people are aware of that, but, and it also can alter the way we relate with other people. I know that I think about the value sorts that we do with a lot of their patients. The majority of them have honesty as one of their values and will full on admit that their eating disorder doesn't allow them to be honest with anybody, eventually about anything. So that's where a values-based approach can be really helpful to start to move them towards their values. Another similarity, high mortality rates, I already mentioned that. Long-term illnesses, so these are not illnesses that are just cured and I'm done. I know that sometimes patients end up feeling a little bit overwhelmed by, you mean I'm gonna have to pay attention to this for the rest of my life? And I always kind of let them know, like, well, yes, and as you go further on in your recovery, it starts to become part of your automatic thought processes. And a lot of the things that you do for your eating disorder that are very conscious now, or for your substance use disorder that are very conscious now, become less something that you have to make conscious decisions about later in life. And they just start to become a way of life, or something that you do without even thinking, reaching out to somebody for support, for example. But yeah, they're long-term illnesses and, we want to be cautious about the word cured. The moral issue, I think about eating disorders. Well, why don't you just eat? Just have a hamburger, will you? I can't tell you how many times I've heard that. Or why don't you just stop using? Or one of my favorites is, well, you can just have one, right? You can just have one beer. I'm gonna get you one beer. Right? So these are the kinds of things that if somebody can't just eat, or they can't only have one beer, then there's something wrong with them, that they lack willpower, or they don't care enough, or they're not loyal enough, or they don't love me enough. And so there's a huge moral sticker that gets slapped on both eating disorders and substance use disorders. And a lot of it is because the symptoms of both, the majority of them are behaviors. And so behaviors often imply, at least in our brains, choice. And there's a lot of research out there showing that when we're in the midst of our use or our engagement, choice is taken away from us. We gain it back, but that's the tough part. A lot of denial, secrecy, and shame, as you can imagine, for both. There's a huge stigma attached to them oftentimes. And then the comorbidity with anxiety, depression, with bipolar disorders, with borderline personality disorder diagnoses, et cetera. There's a lot of comorbidity between the two. Some other similarities. So our behavioral symptoms. We have a hard time managing tension and stress. We've got impulsive kind of an impulsive kind of nature. And then there's that compulsive nature as well, where I like to think of compulsivity as like the moth drawn to the flame, where I might even be thinking, why am I doing this? I don't want to be doing this, and I'm in the midst of doing it anyway. And then a preoccupation with behavior. I'm thinking about it almost constantly. And even in early recovery, we may find that we're thinking about it a lot. And I try to normalize that because a lot of patients feel shame around that, and try to help them understand that this is, you know, your brain is used to thinking about it. We got to give it time to kind of separate from the use and the engagement. The neurobiology. So there are similarities in brain circuitry. In the reward path limbic system, the reward pathways limbic system, right? So I like to make sure I definitely get education to our patients about this. I think it's very, very important. A good video that I have found that draws on a ton of research, and some of you might be familiar with it, is Pleasure Unwoven. Dr. Kevin McCulley put it out a few years ago. He uses the landscape of Utah to really kind of explain the brain and what's happening in the brain when it comes to addiction. And he quotes like a boatload of research. So it's really cool. You can go and learn more about it that way as well. But really helping them understand what cravings and urges are, helping them understand that conversation that happens between dopamine and glutamate in the brain is incredibly important. Really understanding that survival mechanism and how our drug of choice or our behavior of choice becomes the #1 priority in terms of our brain thinking we need it for survival, until of course we train it that we don't need it for survival. But this is why we find ourselves sitting at the bar ordering another beer after our spouse told us they were going to leave us if we did it one more time, that we were told that we were going to lose our job if we came in smelling of booze one more time, and we're doing it anyway. And it's because our brain thinks that we must have that to survive. And we have to train our brain to recognize that, no, that's not what we need for survival, but that takes time. So the neurobiology is very, very similar. Of course, there are some differences, just like even amongst substances, there are some differences here and there, but really taking a look at that reward pathway and the limbic system. And really getting that education, like I said, getting that education to the patients. From my experience, providing that neurobiology education to the patients, and I do it in a very simplified form because I am not a neuroscientist, so it has to be simple for me, takes away so much shame. It doesn't take away responsibility for what we need to do in recovery or how we might need to make amends or whatever it might be, but it can take away so much shame because so many people wonder, maybe I don't love my parents because I keep doing this thing, right? And helping them understand that it doesn't have anything to do with that those are two parts of the brain, two separate parts of the brain. Both disorders involve disruption in appetite and satiation. There's obsessive compulsive behaviors often seen, not necessarily a full-blown diagnosis, but oftentimes as well. A lot of self-destructive behaviors and severe medical consequences. And I will tell you that listing the severe medical consequences to somebody who's deep in it doesn't matter. Telling somebody, if you keep doing this, you're gonna die. A lot of times they're like, okay. Or it just feels like so abstract to them, especially I think with teens, the idea that I might die feels so abstract to them, or that I might hurt myself. That's really hard to connect to that. More similarities. Both have a progression, right? So we see this loss of control, which is where I start behaving. The easiest way for me to explain this is I start behaving in ways that don't line up with my values. I start doing things that aren't like me. And I even might think to myself, who was that person right now? They can both be resistant to treatment. It doesn't mean that they always and forever are, but they're tough. These are tough disorders to address. We see patients and clients continuing use despite negative consequences. And what we determine to be a negative consequence can vary from person to person. So our approach is very much, as I think I mentioned earlier, whatever's causing a problem is a problem. And maybe we need to expand our definition of problem, because I get a lot of folks in who say, my dad was an alcoholic. And so what they're saying is, I know what an alcoholic looks like and it doesn't look like me. Not recognizing that maybe it's just presenting itself slightly differently with a different substance or through their eating disorder, or they just haven't struggled with the same kinds of major consequences, but there are still consequences occurring. So really trying to help somebody hone in, and we use a lot of motivational interviewing with this. Like, is this helping you or hindering you in terms of your goals and what you'd like to achieve, which of course we would have gone over. Both are progressive illnesses, so we see increased amounts of the substance or the behavior needed in order to achieve the same result. And we see a lot of frequent relapses. Of course, many of us know that it used to be that if you relapse, you were kicked out of a program and told, come back when you're ready. We now understand that though there are times when ethically one needs to be moved on to a different type of program or a different level of care. The fact of the matter is that relapses often happen for folks, and being able to sit down and behavior chain with them or talk about what they could have done differently, recognizing the fact that they relapsed over the weekend, but they came in and they told right away, and they called their sponsor and they scheduled a meeting because they realized that they'd slacked off on their meetings with their RD, for example, with their dietitian. That kind of honesty, I think, is really important to pay attention to, because for me, that's working a recovery program. And so really wanting to take a look at that and how can we shore that up. A lot of the risk factors are shared between the two. So the family history, certainly we see it environmentally, where if we're seeing somebody behave in a certain way in terms of food or exercise or with substances, we may either pick that up completely or go the opposite direction. But also our genetic aspect, we've got that genetic component too, that sometimes we just don't know our genetics. And we don't need the genetics there in order to develop a problem, because if we try hard enough, eventually our brain will make those changes and start to equate. It starts to learn, so it starts to equate this feeling with that substance or that eating disorder behavior. History of trauma complicates nearly everything, it feels like, but certainly eating disorder behaviors as well as substance use helps alleviate some of those feelings of trauma for a lot of folks. And we see a lack of social supports. There was some interesting research out there about mice being, social creatures, and those who had developed an addiction and then were put in like social contacts with other mice did well somehow or another. I don't remember all the details of it. I should probably revisit it. And then ones that weren't didn't do well. And of course, people saw the results and said, all you need to do is have friends in order to recover. And that's not necessarily what it was saying, but connection is a huge key component in recovery. And it's one of the things, it doesn't matter what kind of community support group somebody goes to, the one thing they all share is connection with others. So it really is a key component of recovery for folks. So let's talk about some differences. Substances have a tolerance, right? A physical dependence and a withdrawal that is not applicable to eating disorders. Necessarily. I guess not technically medically, but I've had a lot of folks with not just eating disorders, but with spending compulsion, with gambling and things like that. It's not a physical tolerance, but they do feel what feels like withdrawal. It's very psychological a lot of times. They do need more of the behavior in order to achieve the same result, which is tolerance. So while it's not measurable in that kind of scientific terms, people experience those things. But the goal for substance abuse treatment is abstinence. And that doesn't mean, that includes harm reduction, because harm reduction for many people is the path to abstinence, not for everybody, but for many. But ultimately, there are some folks who just can't use. And that would be their ultimate goal, or ideally maybe the ultimate goal. But the goal for eating disorders is to normalize eating behaviors, not abstinence, which is sometimes part of the problem, right? So it can be really tricky to figure out recovery from eating disorders versus substance. Okay, so current treatment approaches, we've got our sequential treatment, which is where we focus on the most acute disorder first, and then you do the rest of them. And treatment is delivered by different providers in different locations. Sometimes they're not even communicating with each other, et cetera. Sometimes this is still absolutely necessary. I'm not saying it's not. There are times when somebody needs to go maybe get some medical detoxification for a substance and needs to spend a little time getting a little bit of substance use education and treatment before they can move on to address some of the other things. Sometimes it's addressing the mood and anxiety first. But I'm finding that those are pretty rare occasions at this point where you would pick out one and focus on it only. It's really challenging to do that now, because I think we have finally figured out that people are more complex than that. There's also parallel treatment, which is when both disorders are addressed at the same time, but with different providers or at different locations. As you can see, this is where things can sometimes fall through the cracks, where misinformation and miscommunication can occur. This is where a patient or client can either intentionally or not split staff. So really, I mean, they can even do it when we're working concurrently together, let alone if I'm, two different providers. So it's helpful to address them both at the same time. And sometimes this is the only option that people have. Currently, there's no evidence-based integrated treatment for treating co-occurring substance use and eating disorders. But what we are finding is that I've got a stack of cards this thick thanking me, thanking ARCH, which is, our addiction program, for introducing them the idea of even considering substance as an issue. And, lots of people have come back and they've made the decision to be sober, even when they left, they had no intention of it. So what I'm seeing is when we address both of these things at the same time, I am very much a part of all of the teams here. I go to the leadership meetings. I have input in all of our rounds with the patients that I'm working with. And, we're all considerate of each other's specialties. And so we're seeing some pretty decent, at least qualitative evidence that it's doing right by our patients. So our approach is a comprehensive screening for both eating disorders as well as substance use disorders, or just misuse or whatever it might be. So we want to take a look at both of those things. We also want to screen for co-occurring psychiatric disorders. We definitely take a look at any medical conditions. We order lab tests, and that includes comprehensive drug testing for all patients when they walk through the door, because this might be surprising to some of you, but they're not always forthright in the intake assessments. And they say, nope, never used a drug in my life. And then they come in with a boatload of cannabis in their system, or, a ton of alcohol or whatever it might be on the drug screens, which says, okay, we might need to have them help us understand that. So we do comprehensive drug testing. The continuous drug testing is for those patients who are designated to ARCH, or if there's suspicion. Really understanding that the independent and combined medical complications of these disorders. It's really crucial in implementation of treatment plans. And, we've got the guidelines in the APA and ASAM, and I want to say NICS, NICE, National Institute of Clinical Excellence. I wonder if they say NICE. Anyway, I digress. And then, of course, the individual treatment plan that encompasses those co-occurring psychiatric disorders, et cetera. The other treatment teams, in terms of integrated treatment, we've got treatment teams that are, okay, let me just do this. Never again will I use the fancy, all right. So treatment teams that are trained in evidence-based treatment. So I mentioned motivational interviewing is a huge amount of what I do here. Because like I said, a lot of people come in and they are not happy to see me. And so we motivate people to at least consider looking at their substance use. It's very different from what I'm used to. When I was in primary substance use, it was go to meetings, don't drink, get a sponsor. And that's true for some folks here, and that works for them. And usually they say, Leah, I need you to tell me, remind me that I'm an addict. I need you to tell me that I have to go to meetings. And I'm happy to have that relationship with them if that's helpful for them. But most people, we have to just kind of talk about, like, well, are you willing to just explore it and see what it means? We want to really take into account stages of change. And how we utilize that to inform our treatment interventions with folks. There are a lot of folks. There's one person right now, for example, who I took a look at the intake, and we ask everybody about substance use, and they were so suspicious. Why are you asking me these questions? I don't have a problem. Normally, I try to get people in for an evaluation within 24 to 48 hours of their admitting. I'm holding off, because I feel like this patient really needs to settle in and start to build trust with their team before we even start to approach that. And then we'll revisit it when it feels like it's time. So that's a little bit of understanding their stage of change and recognizing that if I came swooping in and did an evaluation on them the day after they get here, they may decide to discharge. So we want to really be aware of that and thoughtful. We do ACT here, acceptance and commitment therapy. We do practice DBT, as you may know. Dr. Ellen Astrachan Fletcher is one of our directors here, and so she is trained in both DBT and RODBT for our over-controlled folks, which has been really helpful. Exposure and response prevention, as well as behavioral activation. So we don't, not everybody does ERP. Some people do BA, just kind of depending on if they're struggling more with depression versus anxiety, et cetera. So that's individualized. We don't do a lot of prolonged exposure. That would be more of some of our staff who are trained in it. They do that on an outpatient basis with folks. But written exposure therapy is something that many of our therapists have been trained in. And that can be started at a residential level of care. It used to be that trauma wasn't touched until, you know, they had a solid base of recovery. But what we were finding is a lot of people couldn't establish a solid base of recovery unless their trauma started to be addressed. And written exposure therapy is a very kind of side doorway to start doing that without like the deep rolling up your sleeves, digging in kind of work. And so only certain people are designated for that, and not everybody is appropriate. Cognitive behavioral therapy is something that we continue to rely on, particularly with our binge eating program. Terry mentioned the family aspect of it. We are still doing our family days, which happen once a month. They're certainly looking a little different at the moment, but until we can get back in person, we are still providing that. And we have a lot of recorded material for families and alumni as well that we're making sure they have access to. Medications, we have to take a look at medications that integrate psychosocial interventions with eating disorders and substance abuse. And then the services, as I mentioned, are provided in the same location with the same providers in a stepwise and integrated fashion. Life is never that neat, but we try. The following positive outcomes are associated with integrated treatment. We do see reduced substance use. I mentioned that. I hear it a lot from former patients. Some have just reduced their use, but they have reduced it, and some have decided to stop completely. And so that is always a positive thing. I'm not saying that substances are evil, and there are many people who can use them responsibly. Not all substances necessarily, but the fact is that when we remove them from the equation, they don't even have to be part of the equation. Like, we don't even have to think about it. We can just remove that as the possibility for the cause of anything, right? And that's why I often recommend, at least in early recovery, let's just not use, just so that we're certain that that wasn't the thing that was creating, maybe your medications weren't working as well as they could have been, whatever it might be. We do see improvement in psychiatric symptoms as well as psychiatric functioning. There are decreased hospitalizations. People start becoming more medication compliant. We have to work with a lot of folks around that. They increase their coping skills. We see increased job performance and reentry to workforce for a lot of folks, and there's an improved quality of life. So these are some of the positive outcomes that are associated with integrated treatment. Of course, it doesn't always work this neatly, but any improvement in any one of those areas is something to be celebrated. The challenges with integrated treatment, the facility setup, not every place has the ability to have the space or to keep everybody in one building or whatever it might be. Sometimes medical needs aren't able to be managed with certain facilities, and they do have to outsource to someone else. Sobriety monitoring can be challenging, in certain areas, or having access to some of those things can be tough as well. Sometimes I think in particular with our patients, when they're at the IOP, in particular the IOP level care, and especially now that it's virtual, it's like a free-for-all. Like, at least when they were on site, we'd have a little bit of luck reminding them that our recommendation is that they don't use during their treatment stay with us. And it's really challenging to monitor that now. Sober living communities aren't always available or affordable for some folks, and we can see some family resistance, of course. Family and friend resistance, and honestly, whoever our social support system is. So the treatment recovery model, the integrated treatment recovery model, is that hope is critical. And this, by the way, is a key component of motivational interviewing. Our hope that somebody is capable of change has to be maintained no matter what. And so sometimes that means adjusting our expectations. recognizing that, any movement is change, and that can be a good thing. Services and treatment goals are patient driven. That doesn't mean that we don't have any say, obviously, but we really do want to pay attention to what are you looking to achieve here? What are your goals? Especially when somebody is not quite ready to admit that maybe something is as problematic as it is. It's really important to make it about, well, you're here, so what can we do to move you forward? Respect and compassion for patients is essential. And of course, we know that burnout is an issue. And I think especially right now, burnout is a big issue for a lot of folks. And really, when we can support our colleagues in taking care of themselves so that we can continue to tap that reservoir of compassion and respect, I think it's really important. But, one of the things I love about DBT, and I'm excited to hear, Dana, that you folks operate this way, is one of the key components being that you have those team supervision meetings. And so, recognizing, being able to talk about recognizing, maybe I'm not doing so great with a particular patient or client and need a little support. Maybe we are having a reaction, or our reservoir has run pretty low. So it's really, I think the team thing is huge. I appreciate that. And then integrated treatment specialists are responsible for engaging patients and supporting their recovery. So really, how do we find a way to get them to feel like a sense of agency and ownership for their treatment, and how do we get them to be willing to show up or show up on time? How do we tap into some of that? So we have to get clever and creative sometimes. We have about 9-10 minutes left, and what I have here are guidelines from NIDA, Adaptive with Eating Disorder. There are about 10 of them, I think. I'm not going to go through each one of them, but just kind of pick out a few. Obviously, we know that eating disorders and substance use disorders are complex, but people are complex, so it doesn't seem super surprising to say that, but they are treatable. No single treatment is appropriate for all individuals, and so really figuring out what works for somebody, I think, is important. Treatment needs to be readily available. We're not always able to make that happen. But I think this is where that collaboration, where even if the patient doesn't come to us or doesn't go to you, Dana, finding that place, or at least giving them those referrals moving forward so that they can find the place where it is going to be a best fit for them. And I used to, when I worked at, it was Presence, when I was managing our unit downtown, I'd get phone calls from people calling for some service that we didn't provide at all. And I would give them a few referrals. And I can't tell you how many times they would say to me, or whoever else at the unit picked up the phone and did the same thing. No one else has been willing to give me even referrals. They just say, oh, we don't do that here, and are like done, which always surprised me. And I also understand how spread thin people can be, but I feel ethically we've got to at least give somebody a direction to head in, and it sounds like we both do that. Meeting the needs of the individual, the effective, what does that say? Effective treatment tends to now I get it. Tends to the multiple needs of the individual, not just the eating disorder or the substance use disorder. They are more than just those things. Remaining in treatment for an adequate period of time is crucial. We know that sometimes we are fighting the system in order to make that happen, and hopefully we get creative as much as we can. The group counseling, individual, family counseling, nutritional, other behavioral therapies are all critical components. Medication is a critical component for most people. Relapse prevention medication or medication-assisted therapy or treatments can be really helpful, like Suboxone, Naltrexone, et cetera. And we have to constantly kind of change our plan, much like a good business plan would be revised as needed. We need to do the same thing with treatment plans for patients. There are 12, I said 10, I lied. Medical detox is often first for many people, and likewise weight restoration. Maybe the first step for most people. We're not necessarily doing a whole lot of therapy or treatment at that stage. There may be a little bit here and there, but they're often, everybody's so foggy in those moments that it's really about just keeping them as comfortable as possible and making sure that they're safe. Treatment does not need to be voluntary to be effective. I always say to my folks that external motivation gets a bad rap. A lot of times people say, well, if you're not internally motivated, you're never going to make it. And that feels very black and white to me. I think that a lot of times external motivation is exactly what we need to get us started. And eventually the hope is we get to a place where we're internally motivated. And I also think that there are a lot of external motivations out there that are actually internal in a sense. So if a mother is trying to work on her eating disorder because she cares about her kids and she wants to be a good role model for them, you know, she calls that external motivation. I said, well, why would you do that for your kids? And she says, because I love them. I said, well, isn't that internal motivation? So we can get real philosophical about it. But I think really being really careful about determining something is black or white, moving away from that can be helpful. Monitoring eating disorder related behaviors, monitoring use during treatment. I can't imagine doing treatment without noting whether or not somebody is using substances, because the treatment's just not going to be quite as effective. And then of course testing for things like HIV/AIDS, hepatitis, B, C, etc. And that's it. That's all I've got. I just did a little Mary Catherine Gallagher, for those of you who remember that. Sorry, I like to entertain myself. Any questions come up, Terry?
Nope.
All right. I'm really good at what I do. Either that or you already knew all of this, everybody out there.
Yeah. So if anyone has any questions, please throw them in the Q&A. Any
Let's see. Okay.
questions?
I'm going to mute myself just in case, because Terry, you're breaking up a little.
I think you're breaking up, but there is a question about CEUs and about the PowerPoint presentation. So yes, we will be able to email the PowerPoint to you, and CEUs will be sent as well. I did just get a notification from Ryan that we may need full addresses for CEUs, so we will email you. I think that's a new thing that IMCA is asking for. So we will email you instructions if we need anything else. So we will be in touch with that. Just trying to see if there's anything else really quick. I think that it is it. Leah, awesome presentation. You did a great job.
Thank
I love
you.
the end. You did a wonderful job. It was very informative. I feel like clinically completely relevant and very helpful. So thank you. Yeah,
Thank you
for partnering with us, and everyone else, thank you for spending a little bit of your morning with us. Is anyone else, any of the other panelists, seeing any questions that I'm missing or anything else that we need to address? All right, guys. Hey, well, you are getting some wonderful feedback. I don't know if you're seeing that, Leah.
You're all welcome. Thank you. Thank you for being here and feeding my love of presenting.
You're a natural. You are a natural.
Thanks, everybody. All right.
All right, guys.
Thank you. Take care.
Take care.
Everybody
All
stay
right.
safe.
Bye-bye.